Did you know that you can lose 40% of your bone mass within the first 2 years after a spinal cord injury? And are you aware there are drug therapies that can help? Hi, my name is Wendy Murphy, and this is episode 7 of the Bare Bones podcast, Pills or Poison and Atomic Habits, where we will talk about drug therapies. Joining me is my colleague, Anita Kaiser, who has over 25 years of experience living with spinal cord injury. And our guests, Dr. Anthony Burns, a physiatrist in the Brain and Spinal Cord Rehabilitation Program at Toronto Rehabilitation Institute, a professor in the Division of Physical and Rehabilitation Department of Medicine at the University of Toronto, an affiliate scientist in the Neural Engineering and Therapeutics team at Kite Research Institute, and Dr. Christopher Cernigliero, an investigator in the Spinal Cord Damage Research Center at the James J. Peters VA Medical Center. Welcome to the show to both of you.
Thank you for having us.
Thank you, Wendy.
I'll begin by asking you, Dr. Cernigliero, what happens to your bone mineral density after a spinal cord injury?
Thank you, Wendy. I'd be happy to answer that question. But first, for our audience, I'd like to define the difference between prevention and treatment of bone loss as it pertains to this talk. Prevention refers to during the acute phase of injury, which is defined as first year of spinal cord injury, while treatment refers to medications given at a point in time a spinal cord injury has occurred for more than 1 year and over the lifespan. Immediately after spinal cord injury, there's an unloading of the skeleton. This unloading is very similar to bed rest or even space flight. In addition to the unloading, we also have a decrease or complete absence of muscle contraction. This unloading and absence of muscle contraction causes a breakdown of the calcium stores within bone, a rise in blood calcium, and an increase in the cells that break down bone, known as osteoclasts, and a concurrent suppression of the bone cells that help build bone, known as osteoblasts. This cascade of events leads to a steep loss in bone mineral density over the acute phase of injury. And this loss occurs primarily in the areas of long bone towards the end of those bones. This is known as spongy or trabecular bone. However, as you progress into the chronic phase of injury, which is greater than 1 year, we see additional losses happening to the area of bone we call compact or cortical bone. And this occurs throughout the shaft of long bones. Overall, this decrease in bone mineral density puts individuals with a chronic spinal cord injury at an extremely high risk of lower extremity fragility fracture, with the highest prevalence of fracture occurring at the regions around the knee. These occur because the knee region, unlike other models of osteoporosis and bone loss, is usually the first point of contact when falling from a wheelchair or transfers that occur from a wheelchair and resulting insult.
Thank you for this explanation, Dr. Cernigliero. So, Dr. Burns, I know that there are a number of supplements like calcium and vitamin D that are readily available to aid in better bone health. But can you tell me, at what point does a person turn to drug therapy?
So it'll be my pleasure to address that. But before I do, thank you again for inviting me to participate in the podcast. So when I talk to my patients about optimizing their bone health, I often use the analogy that building strong bones is like building a house. When you're building a house, you need the basic building materials, the bricks, the mortar, etc. Similarly, when one wants to build strong bones, it's important to pay attention to supplying the necessary nutrients or building blocks for bone. Adequate vitamin D and calcium form the foundation for strong bones. Sometimes, however, vitamin D and calcium are not enough. And using the prior analogy, a building crew is needed to take full advantage of the building materials and shape them into a house. So similarly, when one is building strong bones, it can be helpful to have a building crew to maximize the effectiveness of vitamin D and calcium. Medications can play this role. So I would consider adding a medication when bone mineral density loss continues despite adequate vitamin D and calcium, and there's a moderate to high risk of fracture. One can do bone mineral density testing every 1 to 2 years to monitor this and help decide when to introduce a medication.
You used a great analogy there, Dr. Burns. Now I'll ask you, Dr. Cernigliero, What are the more typical drugs used to help in preventing bone mineral density decline?
Thank you, Wendy. Research studies, the clinical trials that have been performed to date have shown primarily a class of drugs known as bisphosphonates. Specifically, some examples are oral alendronate, otherwise known as the brand name Fosamax, or IV-infused zoledronic acid that goes by one of the brand names Reclast, quite effective at preventing bone loss around the hip region. So recently, a class of drugs known as human monoclonal antibody, or denosumab, that goes by the brand name Prolia, has been demonstrated effective at preventing bone loss around both the hip and knee region. So you have to appreciate that these drugs work by partially or totally inhibiting the cells that break down the calcium stores within bone tissue. The prevention or suppression of these cells proliferating or growing prevents the decrease in bone mineral density before it occurs. However, there are common side effects associated with taking these drugs. In persons with spinal cord injury, the most common that have been reported in these randomized control trial have been with oral alendronate, Fosamax, gastrointestinal symptoms such as gastroesophageal reflux disorder or GERD. However, this can be somewhat avoided if individuals take the medication on an empty stomach with a glass of water while sitting up. Where it has also been studied the most is the IV drug zoledronic acid or Reclast. Now, this drug has been shown to exhibit or promote flu-like symptoms over the first 48 hours after initial administration, however, much less after repeat administrations. The most common adverse drug reaction with the medication denosumab has been skin irritations, such as rashes and dry skin or dermatitis. All of these side effects can be treated or prevented by physician. In addition, individuals with pre-existing GI and skin conditions may not be good candidates for these medications. And women that are of childbearing potential should proceed with great caution when receiving these medications and take great care to not get pregnant during this time period. Clinicians and individuals with SCI should use a shared decision-making process that accounts for patients' values, preferences, and comorbidities when selecting therapy and avoiding adverse effects.
Thanks for all of this great information. So on the flip side, Dr. Burns, do you mind sharing with us what some of the more typical drugs are that are used to treat people who have already experienced a decline in their bone mineral density?
Yes. I guess the first point I'll make, as nicely reviewed by my colleague, Dr. Snigliero, is that there's a difference between prevention and treatment. So in contrast to prevention, treatment is defined as an intervention for persons with spinal cord injury who already have low bone mineral density and increased fracture risk. In general, the same drugs that are used to prevent bone mineral density loss can also be used to treat individuals with spinal cord injury who have already lost significant bone mineral density. The benefits of treatment and reducing regular fracture risk far outweigh the risk of side effects.
Some great insights, Dr. Burns. Now, I'm curious to know, as I'm sure many of our listeners are, how long does an individual need to be treated? And more importantly, when can they begin to expect to see improvements in their bone density?
So I'm going to tackle the second part of your question first. So it's important to realize that bone changes slowly and gradually over an extended period of time. So as a result, improvements are often not evident for 1 to 2 years after starting a medication. Also, improvement can be defined as either an increase in bone mineral density or alternatively stabilizing bone mineral density loss and preventing further loss. In regards to how long to treat, it differs depending on the medication. But regardless, I typically counsel patients that they should be prepared for a long-term commitment. And potentially this could be lifelong with intermittent breaks. So for the oral biphosphonates or pills, I typically will treat for 5 years before considering a 1 to 2 year period off the medication. We call the time off the medication a drug holiday. In comparison to the pills, a typical treatment duration for the intravenous biphosphonate zoledronic acid might be 3 to 6 years. The treatment duration for the subcutaneous medication, denosumab or Prolia, is less clear, although the available data suggests that it's safe to use up to 10 years. Afterwards, I would likely consider a 1 to 2 year drug holiday.
I know you've already touched on this a bit, but what type of follow-up is required once treatment has begun? And would this vary depending on the type of treatment the person receives?
Well, regardless of the treatment, I think that reassessment ideally should occur every 1 to 2 years and incorporate bone mineral density testing. This is the best way to assess the effectiveness of treatment and decide whether changes are needed. I would consider changing treatment if bone mineral density testing revealed a progression of bone mineral density loss for 2 consecutive years. This is particularly true if compliance with the medication is good and we know that the calcium and vitamin D intake is adequate. It's also important to rule out other conditions that could affect bone mineral density. And in order to do this, it would often involve blood and urine testing. When a person sustains a broken bone despite being on treatment, I consider this a treatment failure. And this is also another reason to consider a change in treatment approach.
Now, Dr. Burns, many options or drugs have been mentioned. With the number of options available, how does one decide which drug to use?
Excellent question. And there are a number of considerations that we need to take into account when deciding which drug is most appropriate for one given individual. Typically, the cheapest choice is an oral biphosphonate, pills. In Ontario, our provincial drug programs actually require a trial of an oral medication before turning to a more expensive option. My preference among the oral biphosphonates is alendronate, and that's because it has been studied the most for individuals with spinal cord injury. Most oral biphosphonates need to be taken on an empty stomach to facilitate absorption. And as a result, I often recommend that individuals take the medication first thing in the morning before they eat. Some individuals, however, have trouble adhering to this. And so it's nice to know that there's one oral biphosphonate, residuronate delayed release, which can be taken with food. When oral medications are not tolerated due to side effects, or there are concerns of compliance or absorption, alternatives include the subcutaneous denosumab or intravenous zoledronic acid. Since denosumab is administered subcutaneously, similar to insulin, 100% of the medication makes it into the body. And IV zoledronic acid also has a similar advantage. In addition, denosumab only has to be administered twice per year, and intravenous zoledronic acid, otherwise known as Aclasta or Reclast, only has to be given once a year. So this can be very helpful in improving compliance with prescribed treatment.
So I know that research and discovery is always ongoing. Can you share with us some of the latest research to prevent the decline of bone mineral density for people with spinal cord injury?
Thank you, Anita. I can actually summarize some of the research that's taken place in the acute and chronic model. So to date, there's been a few studies in the chronic SCI model, actually, kind of putting the cart before the horse a little bit, where very advanced exercise/rehabilitation treatments. In these cases, it was mechanical stimulation through vibration therapy and functional electrical stimulation rowing were combined with some of the drugs that we've already covered. And those drugs would be oral alendronate, IV and IV zoledronic acid, and also a drug that we did not cover, which is a parathyroid hormone drug known as teriparatide. These studies have not been done during the acute phase of spinal cord injury. But we do know that during the acute phase, the drugs that work by themselves, and there also have been some of those same exercise rehabilitation therapies done alone. So we anticipate that future trials in large numbers of persons with acute SCI will need to be performed to understand the most effective drug and exercise combinations.
Thanks for sharing these great insights. As a final recap, what would your take-home message be for our listeners, Dr. Cernigliero?
Sure, Wendy. In conclusion, there are drugs available to prevent and treat bone mineral density decline. Talk to your doctor about the best drug for you.
Wow, we've covered a lot this episode. Thank you both for your attendance. If you found today's talk interesting, check out our action planning tool on the website, www.scifragments.ca, and feel free to send us your feedback using the survey provided on the website. In the next episode, we'll talk about fracture management.